Welcome to this LEX18 Digital Conversation. I'm Davidson. You know, having surgery is never fun and the recovery can be even more difficult. There's now a service that is offered at Baptist Health to help get patients up and back on their feet with limited and responsible use of opioids as a part of their recovery plan. Joining me today to discuss the Enhanced Recovery After Surgery program, Dr. Thomas Brewster, president of Central Kentucky Anesthesia, and John Edwards, co-director of Acute Pain Service at Baptist Health. Gentlemen, welcome.
Thank you.
Let's talk a little bit about this, because surgery is never a walk in the park. I don't care how minimal it is, billed. It's still, anytime somebody's doing something to your body, it's a process. So tell us a little bit about the history of the recovery program that you have there.
Well, the history of it really started in Denmark. Dr. Kalet is a surgeon in Denmark, and he's a PhD and an MD surgeon, and he had some ideas. People started listening to him. They were a lot different than what had been taught for the last 50 years, so it took a while to catch on, but he wanted to alter the stress response of surgery. Surgery's trauma, how our body responds to that. It was a problem, and he started looking at ideas of what do we do about maybe not starving people for 12 hours before surgery, and how can we control their pain better? Because he foresaw then that our pain control could be better. Those were a couple of big things. There were other things. That's really where it started. It grew through the 2000s to the point in 2010 or thereabouts that England decided that was going to be a standard of care, and they had a commission that was headed by Dr. Mythen, who's a big name in the whole enhanced recovery movement, that led that and made it basically standard of care in England and pretty much throughout Europe. And he brought it over, the same guy actually brought it to the group in Duke. I hate to say Duke here in Kentucky, but they brought it to Duke. And it started in the United States, really in Duke, and has grown rapidly in the United States, but not as fast here as maybe it did in Europe. But it is growing right now. I think it's a very hot topic right now.
Why do you think it's taken us so long? Do you think it's because pharma is pulling against, or insurance companies are not buying in, or?
I can tell you what Dr. Mythen said. Dr. Mythen said in Europe, and he was given all the power at the nationalized health system to make it happen, and all the power to do it.
Right.
And it still took him 2 years.
Wow.
To really kind of make it happen. And he said over here it'll take, and I sat down and talked to him, he said over here it'll take much longer than that, and that's proven to be the case. But I think now as more and more people are seeing the value, and we'll get into later with John, the whole narcotic issue, it is a big push right now to catch up.
Oh, sure. Oh, sure. So let's talk a little bit about the process, the surgical process. We come to the hospital, we have to do the pre-op, we fill out all the papers, because there's always a ton of paperwork. I think that's maybe worse than the surgery sometimes itself. You were talking about having to eliminate or maybe reduce some of the things, the pre-op things the patients have to do that can make it less stressful. Baptist moving towards doing that? What are some of the things that you're doing with that?
Well, it's not necessarily doing less. It's really... It's in a way it's doing more, but it's starting to work with the patient, putting the patient as part of the team, really from their initial visit to see the surgeon. They go in to see the surgeon, they're scheduled for surgery. At that point, ideally the surgeon's staff start talking to them about, we've got this program, here's what you need to know, here's some information we're gonna hand you about it, you're gonna go to the pre-op clinic, and you're going to learn more about it, and your anesthesiologist, when you see them, they're going to tell you a lot more about it, your nurse anesthetist. And you start making the patient part of the system. You start telling them, we're not going to starve you. In fact, we're going to want you to go get you a bottle of Gatorade and drink that 3 hours before surgery, because we want carbs in your system, because that's a good thing for your physiology before surgery. And people have been told not to eat or drink for, so that's a little bit of kind of a hard sell. So you have to explain that to them.
Sure, and a lot of patients, especially when they're trying to get their IVs put in, they're so dehydrated that then you can't even get an IV in them.
Right.
Yeah.
That's true too. And, you start talking, we talked to them about, we're going to get you up earlier after surgery. Ideally, in a perfect world, we may send you home earlier, we may not, but if we can, that's great. We're going to feed you earlier than we used to. We're going to hopefully give you less narcotics than we used to. We're maybe going to do other things to control your pain that are not narcotics.
Right.
But the patient is, I wouldn't characterize it as they do less. They actually are just more involved.
And that makes them feel more empowered.
Yeah, very empowered.
And so then when we get on the back end of the surgery, after everything is done, then your part kind of comes in on this. Let's talk a little bit about the opioid awareness and how you are helping, your office is helping people to put them aside earlier and dispose of them more responsibly.
Yeah, so if we think about the surgical process and the acute pain management that occurs from any kind of surgery you have, whether you have your gallbladder removed or maybe your knee replaced. So, we do lots of things with our acute pain service, with our anesthesia group to help minimize patients' pain, make sure they're very comfortable, but also reduce the amount of opioids that we use, the narcotics that we use throughout the surgical period. So what we know, there's recent literature that's been coming out in the last 2 or 3 years, says that 6 to 10% of patients who don't take any narcotics before surgery will continue to use narcotics a year after surgery, after having a standard surgery, whether it's a minor surgery or a major surgery. So that's a really big number.
To self-medicate for another issue or because of abuse?
Sure. So it develops into like a substance use disorder. Okay. So it begins as, you take opioids home with you or narcotics home with you, your surgical pain resolves, you leave them in your medicine cabinets, and then maybe
You
a
get a
period of
backache
time
or
later,
a headache
you
or-
begin to use them and you
Right.
begin to develop that pattern. So the things that we can do to really help with that and put that into an enhanced recovery perspective, like let's say you're having your gallbladder removed.
Okay.
You'll come to our surgical pre-op room after having gone through everything that Dr. Brewster talks about. And in our pre-op room, we're going to give you some non-opioid medications to help kind of start the pain management process. Simple things like Tylenol, ibuprofen type products, right? And then in the operating room, for most of our surgeries, we will do some type of a regional anesthetic procedure, usually after you're asleep under anesthesia. So just like a dentist would numb up a tooth,
Yeah.
and you're awake while he's working on your tooth, but your brain's not getting that feeling of pain or that
right,
trigger.
right.
So usually after the induction of anesthesia, for a lot of our procedures, we'll place some type of a regional nerve block, whether abdominal block, a block for the chest wall, any kind of extremity, so that during the surgical procedure, your brain is not getting that sensation of pain.
Really?
And starting that pathway of pain. So that
Doctors, so then, doctor, I'm going to ask you then, would patients then be able to be awake during some of this stuff?
Go ahead.
Absolutely.
Really?
So in our joint replacement pathway, for instance, if you're having your knee replaced,
Right.
you'll come to our facility, preoperative room, you'll get things like Tylenol and ibuprofen. You'll get a spinal anesthetic for the procedure, which means both of your legs will be numb for
Right.
about 3 hours, okay? And so what we've learned is that people don't really love hanging out in the operating room with us to be wide awake. So we used to give lots of sedation, and lots of that was opioids, which we realized patients didn't really need. They just needed something to make them comfortable to hang out with us. So now, if you're having your knee replaced, we actually have active noise canceling headphones. We have iPods that we purchased through our hospital auxiliary department. We have a subscription to Apple Music.
You're kidding
and
me.
you get to pick, Dia, what kind of music do you love? Tell me what it
I'm
is.
kind of eclectic. I love smooth jazz.
Okay, so if you were having your knee replaced today, I would create a smooth jazz playlist for you. You would listen to smooth jazz, and I would blend that with just a little bit of some sedation medicine that goes away really quickly, right? Because then as soon as your surgery's over, you've enjoyed the smooth jazz, you had a little bit of sedation, and then in the recovery room, we'll place like a nerve catheter to help you with pain management.
Right.
But the key is we want you up today, walking with physical therapy, eating lunch, interacting with your family, maybe wearing your clothes that you're comfortable
Right.
in, feeling like a normal person, so that tomorrow morning you're going to go home.
So then insurance companies have got to love this because they don't want us to be in the hospital any longer than they have. You absolutely have to.
Sure.
So is this something that you're getting a good response from them as well, and maybe even some support?
Sure.
We don't really talk to the insurance companies much. Now, we do talk to administration.
Sure.
And because we can't really do, one thing I wanted to point out, I mean, it's a big team effort. And
Right.
you can't do this in
In a vacuum.
isolation of just anesthesia. You happen to have 2 anesthesia providers here, but we could have brought you a hospital administrator and a nurse just as easily.
Right.
And or a surgeon.
Right.
Because it's really kind of all of us involved, and it's more of a team approach.
Well, is this something that the patient has to request, that they'd like to participate in this, or is this kind of automatic when you
This
come
is
to
our
Baptist?
standard of care.
Oh,
When you come to
really?
Baptist, if you're coming for a knee replacement or a breast cancer surgery or a colon surgery, this is our standard of care.
We have pathways for most of the specialties. I mean, is an exception or two out there, but
Sure.
if you come, like I said, you come for a total joint, we actually have an incredibly cohesive orthopedic group. I mean, John knows a lot of credit because he's got a passion for orthopedics, and all those people, goes to all their meetings, develop a great relationship with them, where they all basically use the same pathway and protocol. Even guys in different groups, they come to our place, they use a protocol that we all have developed, not just us. I mean,
Yeah.
the surgeons have helped us develop it.
Right.
You know, and the pharmacists have been involved, and the nurses on the floor have been involved. The administration has been involved because we've had to go to administration and say, you know, we need more help. We need you to fund an extra nursing position because this thing has grown so much that we need a little extra help to educate patients and to kind of ride herd on this to make sure everything's happening like it's supposed to.
Right.
And they've done that. So,
That's
you know,
awesome.
that's where the administration comes in. Insurance companies, I don't know. I don't deal with insurance companies at all, but I do
Right.
deal with the administration because sometimes I have to ask them to help.
Right.
And our administration has been very helpful.
Well, now feedback. Are you getting any feedback from patients on the success or what they're thinking or what they're doing with some of the stuff that you're giving to them?
Sure, we've had lots of feedback. We've had lots of patients write letters to hospital administration and to us and things, and that's really important because it helps us understand that they're really liking it,
Yeah.
that they're doing very well. For instance, we talk about insurance companies. I mean, 3-4 years ago, our length of stay on a knee replacement was about 3.2 days. Now we're measuring that in hours. So it's about 36 hours right now
Wow.
for a knee replacement. And those patients love it. They're out of the hospital sooner, they're going home sooner, they're having less pain.
And they can
we
get to
hear from-
rehab,
Yep.
yeah.
And so when those people are at home now with our nerve catheters, we actually call them every day. So we get a lot of feedback from patients because we'll talk to them every day. How are you doing? How are you feeling? How is your pain?
Right.
Can you ambulate? Are you eating well? All these kind of things. So we hear continuous feedback from our patients, and they're very, very happy.
And it's good to know that you guys are staying in touch and that you're not just sending the patient home and then they're kind of left to figure it out themselves.
Yeah, no, we call them for 4 or 5 days while they're at home.
Oh, wow.
Specifically through our acute pain service.
Yep.
Oh, wow.
And actually, John kind of started that when we started sending all these people home with catheters. That was another challenge for us. How do we keep track of all these
Yeah,
people? And
yeah.
you know, John kind of spearheaded a system where
It
you know
works.
he made it work. He even found a company out there that had some technology to help us keep track of it.
Yeah.
This sounds like this truly is a passion for you. Why
really
was
is a
this
passion.
something that was just you're so passionate about?
You know, I grew up, my dad's a nurse anesthetist, as am I, and I grew up, the first time I ever went in the operating room with him, I was 15 years old, and I watched him take care of a little lady who had a wrist fracture.
Okay.
And I watched him do a nerve block on her, and she actually, I don't know if I ever told you the story, listened to music during that surgery, and that was in about 1984, probably.
Wow.
5. And it just really, I think that day inspired me to think, you know, that we can do things differently. And so as I kind of went down that path, it's just evolved into that.
It's amazing when we bring our children into our workplaces,
Isn't
and
it?
then for them to then come and want to do this and then take it. I'm sure your father is very, very proud of you that you're taking it a step further
Sure.
for patients and patient care.
Yeah, absolutely.
Now, for the packets you were talking about for the disposal of medication, many of us make the mistake of if we don't want it, we put it down the commode.
Yeah.
What are you suggesting to do with it?
So now that we've taken care of our patients in the hospital, they've done well. Now they're leaving our hospital. We've worked with our surgeons and our hospital administration to develop opioid prescribing guidelines. And we've worked really through the University of Michigan and a program called Michigan Open, and they've helped define what those prescribing guidelines are. And so they define that by thinking back to that gallbladder patient. They looked at 200 gallbladder patients. They called 200 patients and said, how many opioid medications were you sent home with?
Right.
And how many did you actually take? And so what they found from actual patients was people were sent home with an average of 40 pills, and on the average they took 6.
Right.
So then they fast forwarded, and the next 200 patients they sent home, they actually reduced that to about 15, and then they called those same patients, and they found they still took about 6.
Right.
And so they only had 15, and so there was less opioids that ended up in their community.
Right.
And what we know is really 54% of people who currently have like an opioid use disorder got their first exposure out of medicine cabinets from family members or friends for free, leftover medicines. Okay, so they now have prescribing guidelines for about 30 surgical procedures. So we work through our enhanced recovery pathways and in meetings with surgeons to say, hey, if you're doing a knee replacement, our guidelines say that you should use 30
Pills.
pain pills to
Right.
go home with. And so
Right.
we've worked with them. But then if people are still going to say take 6 or 10, they're going to be left with maybe 20 in the bottle. So what we've done is we've developed a protocol through our Meds to Bed program. And so if you get a filled bottle of opioids from our facility,
Okay.
you will get this brochure and you will get a Dispose RX packet, okay?
Okay.
So this brochure really goes into what are opioids, how to use them safely. It talks about who are the people who are at highest risk for opioid addiction, and then understanding your pain goals after surgery. Like, you shouldn't expect to have zero pain.
Right.
You should expect to have some soreness and some discomfort. It'll get better in a couple days.
Right.
And to be managing that with things like Tylenol and ibuprofen. And then as needed, if you need an opioid, that's okay. We want you to use those, but use them responsibly. And so at the end of that time, say 2 weeks has gone by and your pain is resolved, but you still have those, say, 10 pills left.
Right.
We ask that you open up the bottle, right, and fill this about 2/3 of the way full with just water out of your sink.
Okay.
And open up this packet, dump it in, put the lid on, shake it up, and it solidifies the whole thing and makes it really unusable, undivertible. And then you can throw this in your regular trash. It's biodegradable. It won't hurt our water supply here in Lexington or any other community.
And nobody could fish them out of the
And nobody
trash.
can fish them out of there. Nobody can then abuse these. So then you've kind of closed the loop, right? So
Right.
we took care of you on the front end through the whole surgical procedure, and then we made sure that you and your family and your family's friends are safe by not having these left over in your cabinets.
So total care for the person.
Total care. Total
Indeed.
care.
Gentlemen, thank you so very much for stopping by. And thank you for watching this LEX18 Digital Conversation. For more information, just log on to lex18.com. Until next time, I'm Dia Davidson.